بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. Today, inshallah, we're going to talk about the most common medication that used in labor and delivery units or obstetric nursing in general. There are too many medications, but we're going to focus on the most common ones. Our objective for today, again, to talk about this medication, to list them, to know the indication, contraindication, and if there is any nursing rule has to be done before, during, or after giving these medications. We'll start with our favorite medication in this field, oxytocin. So oxytocin, we know that's the love hormone, that it would be released during breastfeeding and to enhance uterine contraction. So typically when we start the dose of oxytocin, we started to either induce the labor or to augment the labor, and we have to know the difference. Labor induction is when you want to start the uterine contraction for the labor to start the labor for any reason. That could be, for example, if a woman show up in the ER or in the clinic post date, which is like 41 weeks to 42 weeks of gestational, or if she is has gestational diabetes, and she start noticing that her condition is worsening the baby's condition, well-being, like decrease the fetal movement or any reason. So at this point, the doctor would decide to induce the labor, which means start uterine contraction. So the augmentation means if the woman is already in labor and the contraction have started, but it start to take longer time than we expected. At that time, the doctor would decide to give the woman a bit of push to increase uterine contraction, and that would be with oxytocin. So the dose, as you can see, milliunits per minute, and we'll start from 1 to 2 based on the mother's history, and after that dose will be increased gradually based on the response of the mother during labor and delivery to the oxytocin. Of course, we're going to monitor the CTG for the uterine contraction, and after that doctor would decide, or the midwife, certified nurse midwife, if the oxytocin has to be increased or stay the same rate or maybe stop. And the mechanism of action, it's technically it will bind to the oxytocin receptors in the uterus and to enhance the uterine contraction. As we know, if the mother in this medication during labor and delivery, definitely your eyes has to be on the CTG to monitor the uterine contraction, to avoid any hyperstimulations. We don't want to see more than 4 uterine contraction within 10 minutes. 5 would be the definition of hyperstimulus uterus. We don't want it to get to that point. In this case, we have to decrease the rate, and also we have to monitor the fetal heart rate on the CTG to make sure there is no adverse effects on the baby, and the maternal blood pressure. Our second medication here is misoprostol. It's a medication that most likely an obstetric nursing used to induce labor, to start labor, and sometimes it can be like used for to control postpartum hemorrhage. There are 2 other medications, first line treatment, second line treatment. Misoprostol could be also used to prevent postpartum hemorrhage, but most of the hospitals you will see it as the main indication of that medication is to induce labor, for labor induction. So as you can see, the doses in microgram. Each dose will be different on the hospital policies. They have actually this medication should be given in cycles. Different doses has to be given over a certain time of period, and according to that time, we have to monitor the uterine activity to see if the influence of this medication in the uterine contraction. So, and we can provide it as oral, rectal, vaginal, They are all available. I've seen it here in Saudi Arabia. They're being given to the patient, and there are not big difference between how the woman responds to this medication orally or vaginally or rectally, but there are some text about that. The response might be a little bit different, but it's still not proven yet. um, I'm going to say it's not like a rule of thumb, but they will end up having the same effect. um, the mechanism of action, it's a prostaglandin analog. uh, Basically it's just a prostaglandin that stimulates uterine contraction to start the to initiate, to induce the labor. Prostaglandin also, if you remember the lecture of menstrual cycle, we need a prostaglandin right before the ischemic phase to increase uterine contraction, so the period will start, and you will see prostaglandin in many physiological reaction, physiological process in obstetric nursing. Definitely, women who receive this medication, they have to be placed into tachymeter, which is the CTG. You have to monitor the uterine activity, the severity, the duration, if it's regular, just to help us to decide if the mother responding to this medication, if she needs another dose for that medication. And also vaginal examination has to be done to rule out vaginal bleeding, and also to evaluate if there is progress cervical changes as a result of the uterine contraction. We're talking here about dilatation, cervical dilatation and effacement, and all these factors, as you know, will help to make a decision of the mother in labor or not. Magnesium sulfate, I'm sure you talked about it a lot extensively with your professor when you were talking the lecture of preeclampsia. Yes, right, preeclampsia. So the indication is to prevent and treat eclamptic seizure. We don't want the mother who have preeclampsia to progress and have, God forbid, la samahallah, seizure. So that's why we give magnesium sulfate. The magnesium sulfate will act as CNS depressant agent. It will block the neuromuscular transmission in the entire voluntary and non-voluntary muscles in the body. So from the way I'm talking about it, it's a serious medication that might cause serious serious adverse reaction if it become toxic, or the level of this medication become more than what we need in the body. So that's why, as a nurses, we always need to monitor the serum magnesium level. We send the blood sample to the lab to check the level of this medication in the system. We need to check frequently the deep tendon reflex to make sure it's within normal. Respiratory rate, one of the side effects of toxicity, it decrease respiratory rate, so we have to make sure to check the RR and to make sure it's within normal range. Urine output has to be checked, because as a side effect, the patient might have oliguria and falling in the heart rates. And also we need to monitor the patient consciousness level. Any decrease in this vitals, signs and symptoms that might indicate that the patient is having magnesium sulfate toxicity, and we will end up by decreasing or stopping the magnesium sulfate and providing the antidote to this medication, which is calcium gluconate. So for the doses, you will see that this medication is given in a certain way in a labor and delivery unit. We provide loading dose, which is like a kind of larger amount of magnesium sulfate that would be given over a short time of period. So here from 4 to 5 gram over 20 minutes, and then we titrate down or decrease the rate from to 1 to 2 gram per hours. Yes, per hour, and until we see our response that we want to prevent the preeclampsia, and also we need to provide to monitor the sign and symptom of toxicity. So this is magnesium sulfate. Naloxone, it's it's well known of Narcan medication, and it's technically an antidote of um, of antagonist. It's an antagonist receptor of it's an opioid antagonist. It's an antidote for la ilaha illallah, narcotic medication. Technically, it will stop the effect of narcotic medication in case if we see any side effects on the mother and the newborn. So that's why in labor and delivery unit we see this medication in the resuscitator bed, resuscitator incubator bed inside it, or sometimes it will be inside the labor room in case the mother needed this time. And it can be given IV and IM, and the new medication outside, it can be given as an inhaler, but not in labor and delivery room. They use it for addictive patients, drug addictive patients. Naloxone, Narcan, and the RhoGAM, which is immunoglobulin. I'm sure also you talked about it in your presentation and probably in the lecture with the professors. It's given as an IM injection starting from the 28 weeks of gestations. The first dose will be given during that time, and then 72 hours after delivery. And we all know the indication is to prevent RH immunization for RH negative mother, especially if the baby is with RH positive. So we know the physiology behind that already. It's an antibodies that prevent the sensitization of RH negative for RH negative mothers. The most important thing is to know the appropriate time to give this medication, and we already mentioned that. So the appropriate time starting from 28 weeks pregnancy, then the second dose 72 hours after pregnancy to protect next pregnancy. And it should be given also for RH negative mother if they, for example, God forbid, had any car accident, they fell down, vaginal bleeding during pregnancy. At this case also we have to give RhoGAM to them. Terputulin, it's myometrium relaxant medication. It can be given as a sub-Q or IM. The dose is 1.24 milligram. If the sub-Q or IM can be repeated every 15 to 30 minutes, based on the condition of the mother, to prevent premature labor. So we're talking here about premature labor, in a labor before 37 weeks, and the mother start to show true uterine contraction, or let's say any type of severe uterine contraction. Yes, we can provide this medication to decrease decrease uterine contraction in order to prevent preterm labor. And it's a beta adrenergic agonist. It relaxes the uterine muscles, the myometrium muscles. Definitely, the mother will be placed on CTG to monitor the fetal heart rate, and also to monitor the uterine activities. Other side effect we have to monitor too as well. Methergine, it's an IV medication, most likely provided in labor and delivery unit as or postpartum unit as an IM medication. We use it to prevent postpartum hemorrhage. Okay, and it will stimulate uterine contraction, and uterine contraction. It's a alpha adrenergic receptor, and once we increase the uterine contraction, hopefully, if you consider other factors that prevent or cause postpartum hemorrhage, we can control postpartum hemorrhage, inshallah. Definitely, we're going to monitor the uterine tone. We have to do to assess the uterine tone, the one we learned already in our clinical practice, how to perform the uterine assessment for postpartum mother. And we have to also monitor the vaginal bleeding, definitely, because we're dealing here with postpartum hemorrhage, and as a sign of hypertension. It's very important, very important, very important to know that this medication is contraindicated for patient with hypertension, preeclampsia, and cardiac disease. And if there is a contraindication, the patient with any of these contraindication, we can use oxytocin, and as we mentioned previously, prostaglandin can be used, but oxytocin could be like a better choice, mostly for some patients. Penicillin G, yes, it's an antibiotic, we know that, but why we're talking about it here in obstetric nursing? Because it's safe during pregnancy, and you will see it. We use it to prevent infection or to treat infection, and it's given IV. Sorry, given IV. It's given as an IV medication, and it's given to treat GPS, gram-positive streptococcus infection. You know, the swab that we have to do it for pregnant women, vaginal and perineal swab at 36 weeks of pregnancy. Then we send it. If the mother has positive GPS, she has to be placed on penicillin G to protect the baby during her labor. So during the labor and delivery, the woman will receive this medication. And as we know, it works in bacterial cell wall. It's bacterial cell wall inhibition, so it will prevent the bacteria from multiplying and increasing its number. As we know, with any penicillin group derivative medication, we have to do the skin test first for the women to prevent any possible allergic reaction that might happen because of penicillin, which is not uncommon. Yeah, in other words, it's kind of common allergic reaction among patients. That's why we always test for the allergic reaction of this medication. Dexamethasone, it's corticosteroids. It's given as an IM medication. Be careful, it's very irritative medication. So when you give it to the mother, try to be considerate. Give it in a slow rate. When you inject it to the most likely we give it to the gluteal muscles, big muscles, because it's very irritative and in a slow rate. Corticosteroids is given IM every 12 hours for 4 doses. Okay, so sometimes patient has to be admitted to the hospital just to receive this medication. For certain women who are at risk to have premature delivery, and we want to make sure that dexamethasone is given to the mother to meet our indication, which is improve the fetal lung maturation. So if we have a premature baby, hopefully the baby receive the dexamethasone to enhance that surfactant formation, to enhance the lung maturity of the baby. And since it's corticosteroids medication, we're gonna monitor the mother for fluid balance medication, any side effect, hyperglycemia, because one of the big side effect of the corticosteroid medication is increase of blood glucose level, and you are dealing already with a pregnant woman with all the influence of hormones on the blood plasma. This is another side effect. So literally you need to monitor the woman for hyperglycemia. You might just need to check fasting and random glucose while she is admitted. Might take time to develop this side effect, but just be considerate before the patient is discharged. Just check her glucose blood level. Okay, so we are having here some questions. It might help you just to understand, um, to what is basically, if you go over the questions, it links to the objective is this lecture. So I will leave you with this question to read it, discuss it with your colleague, with your classmate, and the answer is already provided. If you don't know why C or D or E the right answer, you can discuss that with your friend. If you don't understand it, if you still need questions, feel free to email me my email, and we can have a quick um, chit chat about this question, making sure that you understand everything. So this is Dr. Sarah Khaifi. I wish you all the best. Salam